Okay, Chair, the meeting's now live.
Thank you, Lisa. Good afternoon and welcome to the Health and Overview and Scrutiny Panel. I'm Councillor Mark Jeffrey and I'm Chair of the Health Overview and Scrutiny Panel. Members of the public are invited to view this meeting online. Those present are requested to keep their microphones on mute and to only turn them on when you're called to speak. Members are requested to keep your cameras turned on at all times. Officers and external presenters are requested to turn on your cameras on only when you are presenting your reports or answering questions. Just to let you know, members have read the reports, so the presenters please just highlight any developments that have occurred since the publication. If you would like to speak, please write your name and RTS, request to speak, in the chat function or put your hand up in the chat function. I would now like to invite those present to introduce themselves. So let's start. Councillor Matt Atkins.
Hello, Councillor Matt Atkins from Portsmouth City Council, Caution Ward.
Thank you. Who's next? Councillor Stuart Brown.
Afternoon, Councillor Stuart Brown, Portsmouth City Council, Fratton Ward.
Thank you. Councillor Judith Smythe.
Councillor Judith Smythe, St Jude Ward, Portsmouth City Council.
Thank you. Councillor David Evans.
I'm the councillor for Horndean Ward, Ward in Horndean in East Hants District Council.
Thank you. Councillor Vivian Actual.
Yes, good afternoon. Councillor Vivian Atchwell, Ward Councillor for Whiteley and Shedfield from Winchester City Council.
Thank you. Councillor Julie Richardson.
I'm still having trouble, Chair, trying to get a picture on there. But anyway, I'm Julie Richardson. I'm the councillor, Havant Borough Councillor for West Hayling.
Thank you. Councillor Martin Pepper. I think
you're on mute then, Martin.
Mute.
Welcome to the 24th century, everybody. I'm still not quite anywhere yet. Right, my name's still Martin Pepper. I'm still a councillor and I'm on the Gosport Borough Council.
Thank you. And Councillor Graham Heaney.
Yeah, I'm Councillor Graham Heaney. I'm a Labour councillor for St Jude Ward in Portsmouth.
Thank you very much. Now, are there any apologies?
I've not received any apologies, Chair.
Okay. I was given apologies by Councillor Leonie Oliver. So could you record those, please?
Yes, will do.
Thank you. So moving on, so we're going to declarations of interest. Has anyone got any declarations of interest to declare?
No, Chair.
No, that's it. Thank you. Okay, so we'll go on to item 4. It's a South Central ambulance service. So could we have Tracy? Sorry,
Chair. Did we do the minutes of the previous meeting?
We didn't. Thank you for the prompt. So going through it. So yeah, item 3, minutes of the previous meeting. Going through the previous meetings minutes. Has anyone got anything on page 3? Our item, our page 3.
No.
Page 4. I know there are some actions here for Andy Biddle, but he's obviously got his report coming up later on. It says page 3, but it's gone back to page 3. But it's I think that's a technical error. And then it says page 4 again, which starts with item 21 and 23 and 24. And then we jump to page 7, although I think there's just an error there. No, page 8. Okay, that's it. So thank you. Okay, so agenda item 4, South Central Ambulance Service. Tracy Redmond, please. Tracy, could you give us a brief summary of your report? And then members will ask questions.
Of course. Thank you, Chair.
Thank you.
Afternoon, everybody. Clearly, we take the report as read, as you've described, but just in terms of highlights, sorry, bear with, an IT issue. I think members are aware of the introduction. We are focused very much still on working with our partners in terms of ensuring that our patients receive the right care in the right place at the right time. We have a number of different appropriate options for patients now rather than conveying them to ED, and work continues on this really important area. In terms of demand, we've seen demand fairly stable through previous 12 weeks before Christmas. We do see an increase over the Christmas period as expected. However, that has not particularly dropped off, and we're still seeing around 1,900 incidents per week in the southeast area in terms of incoming demand. So it's exceptionally busy at the moment. And with regards to that demand, we do see in the southeast area of SCAS, which is the Portsmouth Southeast System, we do see a higher percentage of more poorly patients than we see across the rest of SCAS as well. In terms of performance, performance is a challenge at the moment, and we have action plans in place, in particularly around Category 2 performance, which is in line with national direction for all trusts with regards to Category 2 performance. So Category 1 are immediate life-threatening patients, which is a fairly small percentage of our workload. Category 2 patients are emergency patients who do need an urgent response, and that's about 60% of our workload at the moment. I was asked by the panel at a previous meeting to provide some comparison against other ambulance trusts, which you will see in the table there, highlighting the green areas where we are above average, and the red where we are not so. As you can see, the last week in December, we did very well, green across the board, but continue to have challenges with performance. Particular focus on Category 2 performance, which you can see.
We can't see the colours, Tracy. Tracy, we can't see colours on our reports.
Oh, I do apologise.
Could I just check, Lisa, is that something that is done when the council is collating all the information, or is it something that we should ask the ambulance trust to see if they can provide us a sort of different format in the future? Could you give your advice on that, please?
Yes, we obviously colour printing is very expensive, so agendas tend to just when we print the agendas, they just tend to be black and white. But obviously, members can, if they want to view certain things, they can view it online as well. Yeah, so I don't know if
just Tracy needs to explain what we're looking at, which shade of grey. That's all. I think we must not print in colour; it's too expensive. But we can't really have a report saying red and green because we can't see them.
So it is colour online, but it's referring to page 13 of the report. That's right, isn't it, Tracy?
Yes. So
it's all in grey. It's all in grey.
Okay, so if I just summarise then, so the areas where we have had significant focus have been around Category 2 calls and appropriate conveyance to alternatives other than ED, most areas of which we are above average against other ambulance trusts. Those that are in colour, those are the green ones. But clearly we have still got some work to do across some of the other areas. I was also asked to provide some data on the last 5 years in terms of performance, which hopefully people can see there on the following table. You'll note the increase in Category 1 and Category 2 demand year on year, pretty much for the last 5 years, indicating a higher acuity of patients coming into the ambulance service. And whilst that causes challenge, that also does indicate that as a system and collectively, we are providing alternatives for those lower acuity patients, which is quite right, because that's the best thing for the patient. But those higher acuity calls do take us longer to manage, because they're more complex and do create challenges in different ways. But for us to be focused on those very poorly patients, it is actually the right thing to be doing. In terms of challenges, we are across the NHS and indeed the ambulance sector in the UK under significant pressure at the moment. We operate under REAP levels, and SCAS have been at REAP 4, extreme pressure, since early December. And in fact, on Tuesday of this week, SCAS did declare a critical incident, which is actually the next level up, whereby we were finding it difficult to maintain our critical services. What that does is it allows us to focus resource to the most poorly patients. It does mean that some of our less poorly patients don't receive a timely response, and we do work hard to direct those patients elsewhere. But there have been some patients, unfortunately, that have to wait quite a long time, the less poorly patients. But we are focused everything on getting to our most poorly patients in a timely fashion. We are still in that position as we speak today, and is being reviewed twice a day at the moment within our organisation. In terms of transformation, we have a new programme running in SCAS called Fit for the Future, which is going to have significant change for us in how we operate, how we deliver our service, what staff mix we use. We're looking for more clinicians now into our skill mix. There'll be a review of our estates, and our strategy for SCAS has been refreshed in line with this. So there is a team now working on our transformation, a dedicated team, to ensure that we are fit for the future and we can continue to deliver our services going forward. I have highlighted patient care there because it is and will continue to be at the forefront of everything we do. Another one of our challenges remains resilience within our system. That for us plays out in handover delays at the hospitals. This means that we're unable to respond to some patients because we're unable to offload ambulances at the hospital in a timely fashion. Clearly we'll hear from the team at PHU, but the hospital is full, and we are all working together to try and mitigate that risk, but it certainly does have quite an impact in terms of our ability to respond to patients. I think I've spoken about improvements and Fit for the Future. The improvement plan still remains in place, the one I described previously, with some key areas that we continue to focus on whilst we do our transformation as well. So just in summary, really, it's a very challenging time. There's a lot of effort going into making sure that our patients stay safe, and we're able to look after our staff, and we're able to work collectively with our partners to ensure the best possible outcomes for everybody.
Thank you, Tracy, for that report. So members, do you have any questions? I've got Councillor Judith Smythe. Thank you.
Hello. I mean, I understand about the pressure, especially this time of year, and you've described well what you're doing about that. Have we got any evidence in terms of unforeseeable and unexpected additional deaths because of the pressure that you're under?
We do have a robust system for reporting adverse incidents where there may be patient harm or death. And this is reviewed collectively with our colleagues from the ICB and quality team to make sure that where incidents like this do happen, that lessons are learned and that we can put things in place to mitigate that in the future. So there is a very robust and joined up system to allow us to do that.
So I think we need to see those figures, and it's about avoidable and unforeseen additional deaths. And I don't know how you categorise that exactly, but there have been some reports in the media about the reports overall across the NHS. And I mean, certainly that is, for me, the sole purpose of doing any big reorganisation is to reduce the number of avoidable and unforeseen deaths. And in other words, that crucial figure of additional deaths because of certain reasons within the system that can be attributed. And I wondered if we'd be able to have that information in the future, because actually, you know, if you see a report, which is a great report about this, with all you're trying to do about it, I don't really care about that. I care about impact on patients and increased mortality and morbidity, increased mortality and morbidity. Yeah. It's, you know, that's what we're here to do, is to make sure the NHS is doing its job. And this report leaves out anything like that.
Of course, I can certainly bring that into the next report. Thank you.
Thank you, Councillor.
You know, all the times when... sorry?
No, sorry, go ahead, sorry.
Well, all the times in which boards like this have been criticised is because we don't ask or get the right information. We don't ask the key question, which is, does any of this action make any difference at all? I'm sure it does, don't get me wrong. But we need to know, we need to be reassured or not. And if we're not reassured, we need to put pressure on where it's due.
You're on mute, Chair.
Apologies. Thank you, Councillor Judith Smythe. Next, I've got Councillor David Evans.
Thank you very much, Chairman. Transformation review. I've read the report and comments on the previous page about a review of the previous 5 years data shows a general declining performance. And I just want to ask about the transformation review, because I spent the last few years of my working life moving over into systems engineering, and my approach to as a systems engineer to a transformation, not just a reorganization, but a transformation, would be to begin with actually working out what your customers want, what they need, and going on from there to make sure that the system is designed to do everything that it needs to. And that's because not only do things change a lot in the medical world, don't they? And what you can do with paramedics and all sorts of things changes dramatically. So is it that are you actually going to have a review that starts with the very start of what are we here for, and going forward from that to say, well, we're here for this and so on, basically a systems engineering review approach? Is that how you're taking it, or is it, I don't wish to be pejorative, but is it just an attempt to reorganize things? I'd like to, if it's as serious as you're suggesting it is, your decline in service, I would like to suggest that a thorough review of what you're there for, starting with what you're there for, wouldn't be a bad approach.
Thank you. Yes, part of the review is around how we organise our services to make sure that the patients get the right care in the right place at the right time, because historically we've been a 999 service that picks people up and takes them to hospital, which is clearly not appropriate for many of our patients. So part of the reorganisation is around what do our patients need, where do they need for that to happen, and when. And that will be part of the transformation, and then building the right workforce and estate to be able to deliver that.
Thank you. That sounds about the sort of thing that I was thinking of. So thank you.
Thank you. Any other councillor questions? While people are thinking, I've just got a quick question. On page 14, the QA handover delays, hours lost, there's obviously sort of a trend there upwards. Is that to do seasonally? So is it normally quieter in the summer months and busier in the wintry, colder months when there are more things like, seasonal flus and slip hazards and things like that?
Yes, it does tend to be. It does tend to be more seasonal.
Thank you. Okay. Councillors, do we have any other questions? Councillor Ackwell, please.
Yes, thank you, Tracy, for the report. I just wondered, I don't know if you can answer this one or not. Is the increase you're finding because people aren't able to get GP appointments? So they're just ringing 999 instead?
To be honest, we don't have any evidence to suggest that. And as I've said, a lot of the patients that are calling us now are very poorly, so therefore you may need a more quicker response than a GP may be able to give. I know there are challenges in primary care, but we don't have evidence to suggest that that's directly impacting on what we're doing. We do have good access to primary care colleagues if we do need them once we're on scene. So.
Okay, right. Thank you very much. Thanks.
Thank you. Next, I've got Councillor Martin Pepper.
Yeah, thank you, Chair. Back on page 14 with these handover delays, I get that there's 1,000 in the 23rd of the 10th and all that business, but what is that? I think I've asked this before, actually. What is that as a percentage of hours of availability? I mean, is 1,000 hours a huge chunk of what we could provide?
So we put out around, so obviously these are weekly figures, we put around 500 hours a day operational hours on the road. So 20%. You're on mute, sir, but I could get you some more accurate figures if that's helpful.
No, I'm just going to go back to school and work this darn computer, but I apologise. 1,000 hours at 500 a day, that works around about 40%. Would that be your understanding?
20%, I think. Or do we all need to go back to school?
Are we talking about 7-day weeks or 5-day weeks? I beg your pardon. I should have started with that.
That's a 7-day week.
So 7 times 250, 1750, I think. And we're losing 1,000. Guess even worse. But you see what I mean.
May I come back to you? May I clarify and come back to you, if that's okay?
Yeah, all it needs to be. I mean, it seems like a lot, but is it? Is what I'm trying to get at.
Yeah, we can take that as an action for getting for the next meeting, so that'll be useful. I've got Councillor Matt Atkins next, please.
Hello, Tracy. Thanks for your report. You may not be quite the right person to ask. I'm sorry you already covered this. Do you have any insight into why serious health cases are becoming an increased percentage of the ambulance workload? Are people sicker, and kind of broadly with what? Or perhaps that's more of a public health question.
I don't actually have the answer, but I do think that we've got some fantastic community teams within this system, and they are looking after some very sick patients in the community. So the point at which they dial 999 may be later than perhaps other areas, because they're being very well looked after by our community teams as well.
Do you have any follow-up, Councillor Atkins?
No, thanks. No, I mean, I might. I probably won't be able to stay that long, but I would possibly direct that question to the public health report later. But I don't know. Yeah.
All right, there we go. Councillor Pepper, are you back with us with a new question, or was it a legacy hand?
As it happened, I am, but I don't know why I put my hand up twice in the first place. I think it's around about 30%, just under 30% of the time if you're talking about the 1,000 hours, which does seem a lot, actually. So it must impact on all the other numbers you push up about how often it takes you to get various C1, C2, C3 to hospital, if that is appropriate. And thank you, Judith, for agreeing with me. I got there in the end.
Thank you. Any other councillor questions?
I mean,
Councillor,
even if it's 750, it's a lot. It's down to 23%. So Tracy wasn't far off with that either. But it's still too much, and you can see why the system is in real trouble. Is it for lack of money, or is it for lack of qualified staff? What are the main weaknesses that are creating this problem, or is it simply because increased demand and increased acuity?
I think it's a combination. I think it is increased demand and acuity, and I've no doubt my colleagues from PHU will be able to support with answers around challenges of offloading the ambulances and the challenges that they face within the hospital that contribute to that as well. It's a whole system challenge, to be honest, with regards to community beds and discharges and various other things. Not my area of expertise, I must say, but it's not one thing, to be honest. It's a variety of different aspects that contribute.
Thank you. Councillor Martin Pepper, you've got your hand up.
For whatever reasons, Chair, my hand won't go down at the moment.
Okay.
So
We'll see. Oh, it's gone down now, so that's fine. Thank you.
yeah, I'll just press the raise button again, so I don't know what's going on.
No, we didn't want you to miss out. So okay, thank you. Councillor David Evans.
Yeah, I just wanted to come back because of what Councillor Smythe comments was that what I'm reading and what Tracy Redmond said, I'm reading that there is what the ambulance service is detecting is that there is a mismatch between what they are providing and what the customers actually want or need in whatever way. So more money wouldn't help that. If you've got a mismatch in that way, what you have to do is redesign the service in order that it more closely aligns with what is needed by the customers, if I can call them customers, but patients. So I hope that's what you're doing, Tracy. But that's what I understand you to say you're doing to get that alignment more accurate.
That's right. I mean, we are redesigning for that very reason. That redesign does take investment, clearly, as folk will know. So there is a financial part to that as well to make progress.
Thank you. Are there any more member questions? No? Okay, so thank you very much, Councillor Tracy. Thanks for presenting that report and for taking our questions. We'll go on to the next item now. So it's item agenda 5, and it's Portsmouth Hospitals Trust. So we've got Penny Emmerich and Anne Thomas, I think. Penny, could you give us a brief summary of your report, and then members will ask questions? Thank you.
Of course. Good afternoon, everybody. Thank you for having us here again. As you say, I'm joined by Anne Thomas, our Deputy Chief Nurse, as well for this conversation. The report tries to respond to some of the questions and discussion that we had last time. And so you can see that it largely focuses on our winter plan. And I can definitely connect to some of the things that Tracy was just talking about there, because there were a number of conversations about what causes us to call a critical incident, and what do you need to do to step out of that. And as Tracy has just said, both Scouse and Portsmouth hospitals are running critical incidents. And I hope what the paper describes to you is that effectively we get to a point of needing to call a critical incident when the demand or need for our services significantly outweighs the capacity that we have available. And what you might see occurring when that happens is that there are even greater delays in the system. So we called a critical incident 3 weeks ago now because we were at a point where we did not have the capacity in the hospital to be able to safely treat patients in a timely way. One of the indicators of that was that we had a significant number of patients awaiting handover from ambulances, and our partners at SCAS were being delayed in being able to reach patients in the community. So there was a significant amount of risk in that position. And to Councillor Smythe's points before, we know that at any point across the pathway where there are delays, there is a greater risk of harm. So it's probably or possibly more obvious at the really acute end with ambulance response times, but equally there is very strong evidence that demonstrates where patients wait significant periods of time in an emergency department, there is also an increased risk of harm associated with that, particularly as you get over 6 hours, it significantly increases in terms of the risk to patients. So what we presented last time was not only our Portsmouth Hospitals plan, but that in the context of the health and care plan for Portsmouth and South East Hampshire, because our ability to achieve our 4-hour performance standard and the ability of SCAS to achieve their category 2 response times that Tracy has been talking about is really linked to the overall capacity that we have in the hospital, because at the moment we are not always treating patients in the best place for their needs, and therefore we're using capacity for things that could be better done elsewhere. So we, as Tracy has already said, are significantly over-occupied. So I think the graphs that we have shared demonstrate to you the increasing occupancy in the organisation, despite the fact that we have increased the number of beds that we have available. We have also had to increase the number of escalation beds that we use or surge areas that we use. And the reason recently that we have called the critical incidents when we have is because we have not only exceeded our bed base, we've exceeded our escalation capacity, and then we are needing to use what we describe as surge capacity to be able to respond to the needs of our patients. And that is a function of, yes, increasing demand at the front door, some of which you've heard me describe, but it's also a function of not being able to discharge patients when they no longer require care from the hospital. And of course, once your stay in hospital or your treatment in hospital has been completed, it is absolutely better and safer for patients to be discharged to their next place of care. We do not want to be keeping people in hospital for any longer than they need to be to meet their needs. So I think that's the key bit in terms of the winter piece, and trying to connect that to some of your questions already and to where Tracy has come in and join those stories up together, because genuinely our ability to deliver safe services to the performance standard is absolutely linked to what we do together across health and care partners. I've also included there a piece about the industrial action. And we really do need to get to a place where that dispute between the doctors and the government is resolved. The most recent strike action came at one of our busiest periods at the beginning of January. So the combination of reduced staff and increased demand was very challenging to deal with. And then I've also included an update on what we describe as building better emergency care, but that's our new emergency department that we had the topping out ceremony for just pre-Christmas. We are on track for that to be open for, I'm going to say this winter, but winter 24, because we're not yet out of winter 23, but in this certainly calendar year. But I think the really key bit to say around that is, while that is a fantastic, or will be a fantastic facility for our patients and staff, we do need to make sure that we're addressing some of the root causes that we've described in this paper around the occupancy of the hospital, so that we can make sure that we don't have the level of delays that we have reported in this paper.
Thank you, Penny. Actually, before we go to members' questions, I just wanted to, as well as thanking Tracy Redmond, I just wanted to say that your report was noted, and you're welcome to stay. But by all means, if you need to leave the meeting, please do. But you are welcome to stay if you want to as well. So thank you for the report there. We'll go on to members' questions. So I've got Councillor Judith Smythe.
Thank you for this report. It was interesting and useful. What shocks me very much is that the 20 or so years since I was chair of the Health Authority, it's exactly the same problems but worse, which is upsetting overall. I'm just asking how many of the patients presenting as emergencies have got COVID now, and just a brief sketch out of what that looks like in terms of a graph for the last 3 years probably, because I know we've had a bit of a surge, but I also know there are reduced numbers coming into hospital, and it's just like, I don't need actual figures, but just a more or less sort of report very quickly.
Yeah, so we are not seeing concerning levels of COVID or flu at the moment. We did have a peak and they've dropped off slightly. I haven't got the actual numbers. We can share them with you. The thing, though, that I would say about the COVID comparative numbers is, of course, our testing regimes have significantly changed, and therefore we're only testing patients who are symptomatic, and therefore the numbers will not be comparable over that 3-year period. But certainly we're not seeing anything in the public health data that gives us any more cause for concern than we have had over recent weeks.
Councillor Smythe, you're on mute there, but I think you might have a follow-up. So do you want to do a follow-up?
Yes, comparisons with, say, 2020 would be about the same as now, would they, or is it still more?
As in higher levels of COVID than we had in 2020?
Well, we didn't have it in 2020, but higher levels of people in with respiratory diseases and that sort of thing.
I would say respiratory infections are at about normal levels for this time of the year.
Thank you.
Thank you. So next I've got Councillor Stuart Brown.
Thank you, Chair, and thanks, Penny, for the report. I wanted to ask a question around the critical incidents, and particularly where you mentioned the Breaking the Cycle week. Mm-hmm. So I don't know what your normal process is at the end of a critical incident, but can you give us some detail about, is there a sort of an after-action report after every incident and making sure that lessons are learned?
Yes, absolutely. So I'll talk to you about that, and then I'll connect that with the piece about the breaking the cycle. So yes, from a emergency planning perspective, we do our after event reviews to make sure that we're embedding our learning, and we will do that internally, but we will also do it with system partners as well, because some of the criteria that we set for being able to step out of a critical incident are linked to the things that we're able to achieve together with our partners. So we will do both of those things to make sure that where possible, we're either embedding our learning into business as usual to avoid us getting back into that position again, or we're being clear that those are step-up actions that can be part of a future critical incident response. What we describe in the Breaking the Cycle piece, and you'll see from the graph, it ran from the beginning of middle of December all the way through to the middle of January. And that was because what we were anticipating was this significantly increased level of demand and therefore risk of that demand exceeding the capacity. And what we were trying to do was, as a system, take some of those preemptive actions to significantly reduce the occupancy of the organisation so that we could get through those bank holiday weekends, get through those periods where we might have reduced staffing. And what we try to do in those Breaking the Cycle pieces, so they are internal hospital actions, but also as a Portsmouth South East system, is to try to take all of those things that are routine practice alongside other things that I've referred to in the report, like the getting it right first time recommendations and the 10 high impact actions, is to just do that reset piece that says, are they still happening? Are they embedded? Are they happening to the extent that we would want them to be? One of the challenges or questions that we often get around this is the examples of the things you're doing during a break in the cycle sound like all the right things to do. And they are. There's nothing sort of additional or special in them, but it is about making sure that we just do that reset piece with our partners to make sure that we are consistently and routinely doing the things that will make the biggest difference, because we have to smooth things across the pathway to avoid the delays at individual points. So unfortunately, the period that we ran it in, for some points of that, we were also in critical incident, but that just meant that we refocused resource. And as Tracy described earlier, a critical incident allows you to refocus towards the highest risk things. But what that means is, into the long term, some of those things that were lower risk at that point in time then experience further delays, which causes you further risk down the line. So it can only be for short focus periods of time, ideally.
Super. Thanks very much.
Thank you. I've got a quick question on page 23, which obviously leads from page 22, occupancy levels for the last 12 months. With the summary of the data from January 2023 to December 2023, there's obviously a big difference between the percentage at beginning of January 23 and what will be the end of last year. Is there any sort of special commentary on that, or is that to do with the whole situation that you've already described in terms of strikes and other things like that?
Yeah, so I think rather than perhaps the industrial action, it's more linked to the capacity that we have across the health and care system. So we have seen changes in demand for our services. So not only volume increases, but as Tracy's described, that complexity, and during the winter, we get an increase in attendances of those more frail, more complex patients who therefore stay longer. So the demand curve goes up over those periods. But equally, if we then haven't got the capacity to respond to that, and that isn't only our hospital capacity, but that would be community, mental health, local authority capacity, that's when you then see the increasing occupancy, because we're having to use our escalation and surge areas in the hospital for patients whose needs could be better met somewhere else. So
obviously you can't predict the future. None of us can. But for January 2024, there's likely to be a big difference compared to the 12 months earlier, I guess. Is that likely from this data?
So the occupancy is increasing, and it's increasing on a higher number of beds. So the bed utilisation might be the other thing to look at, is absolutely going up. And we have actually done a forward look to next winter already. And unless we make some significant changes, and to Councillor Smythe's point earlier about it's the same root causes, we must do something fundamentally differently in terms of how we deploy our resources across health and social care, in order that we don't perpetuate the challenges that we've described in this report.
Thank you. That's really candid and open, which we appreciate. So in what sort of timescales will there be sort of an action plan for that, and will it come back to us, or?
I think the place that it comes together is where the providers and the commissioners in this patch look at our plans over the next at least 12-month period. So when we set our contracts for 24-25, what are the assumptions that we're making together about the demand we expect to see, and therefore what is the commissioned, paid for activity or capacity in each of our providers? And then there'll be a refresh of that for winter. So I think some of this is, how do we have the conversation together with you, with all of the partners, as well as looking at it through the lens of the individual provider performance.
Can I just say as well that the data that was provided, especially the follow-on data, is really clear, and it's quite nice to have a sort of longer time frame to be able to look at things. So on a personal level, I appreciate that, because I know sometimes we think we don't get all the data that we would like to see, but I thought it's a really good example of the sort of thing we'd like to see. So thank you. I've got Councillor Axwell, please.
Thank you, Chair, and thanks, Penny, for your report. So we know we're going to get a lot of extra housing in the area. You're already saying that the hospital's struggling kind of at the moment with bed capacity. How far in the future do you look at your plans? 10-year plan, 15-year plan? What can you do to increase beds?
Well, so there's I guess there are some choices to make about which is the capacity that is most needed. So we have already increased our acute bed capacity winter before last when we opened our new beds, and we reconfigured our internal capacity as well to create same-day emergency care, which, although isn't extra physical space, we are able to treat more patients through that space than if it were just bedded capacity. The challenge we have at this time of the year is that those same-day emergency care facilities that should be doing that and treating our emergency patients most quickly become bedded with patients overnight, because that's the thing to do at that point in time. But unfortunately, what you see when you have a hospital as full and as busy as ours is that the processes become inefficient because you're working out of spaces that you're not used to working out of. But where we have significant numbers of patients still at the moment whose needs will be better met somewhere else, I'm not sure that it's right to keep adding to acute bed base, because it is ideally we would be focusing our capacity towards the patients who only need acute care. So that's why I think your question about over what time horizon do we look at this, we need to be doing that from a system perspective. So what do I need in the acute trust versus what my Ron and colleagues need in community capacity, and what do we also need from local authorities? So we've done some of that modelling. We did it as part of the business case for the new emergency department because we had to make assumptions about what the demand would look like to assure ourselves that we were building a facility that was fit for the future. But I think the annual process that I described around our capacity planning is our opportunity to keep refreshing that, to make sure that we're making the right decisions based on the demand we're actually seeing rather than the demand that we might have predicted.
Okay, thank you.
And before I ask members if there are any other questions, I know we've got Anne Thomas from the trust as well here. I'll just, if you did want to speak, you've got the opportunity to just let me know. I didn't want you to ignore you or anything like that. So.
Thank you. I don't have anything further to add though, but thank you.
Okay. Are there any other member questions? No, that's fine then. So thank you very much, Penny and Anne, for coming today, and we note your report. If you want to stay, you're welcome to stay, but we realise that if you need to get on for
can the minutes say something like we note the report with concern? We didn't just note it. We're all really worried about it, full of hopes that Penny and her team can pull it off. But it looks very dire. And just saying we note it is a bit wet, really, isn't it?
Yeah, let's have that then in the notes. And actually, I've got Councillor David Evans next now.
Well, yeah, Councillor Smiley, you make a very good point. I wasn't going to say this, but since you made that point, I think I shall. Page 23, you talk about just whipping back to it. The junior doctors strike and while pay is a matter for government and trade unions, yes, it is. But an organisation of your size, which has no power to negotiate with its employees about their pay and conditions, I think it's a serious disadvantage. For instance, I just had a look at the average house price in Portsmouth. It's 285,000. Where my wife comes from, in Gainsbury, Lincolnshire, the average house price is 134,000, less than half the price of a house in Portsmouth. So, in order to recruit and retain staff, without the capability of negotiating pay and conditions, my question is, do you feel that puts you at a severe disadvantage? I'll leave it at that. I know it's a highly political question, but I don't think it's irrelevant.
So you're right that we aren't in a position to influence the national paying conditions, which is why we do hope that there is a resolution found for that. Meantime, we focus on the things that we can influence that do equally impact on employee well-being, satisfaction, desire to come and work in Portsmouth rather than somewhere else. So those things that we can influence about what does it feel like to work at Portsmouth Hospitals Trust, we absolutely focus on. But I also recognise that when you describe the numbers that you do in terms of just disparities in house prices, we absolutely can't ignore the impact of money on people's choices as well. But as I say, that we have to leave that to the national negotiations, but we'll do what we can to support our teams to feel valued as part of our organisation as well.
Having a local medical school is going to help, isn't it? Local medical school will help. Good move.
I hope so, yes.
Thank you. Are there any other member questions? So we'll note that report with that we're very concerned, and thank you for coming today. We'll move on to item 6, which is access to primary care, and Bernie Allen. Bernie, could you give us a brief summary of your report, and then members will ask questions, or have I just missed the? I think Bernie's been called away for an incident. An emergency incident. There's a message here.
Yes.
Let me just read it out, just to be clear. We've had an email through saying that Bernie's had to attend an emergency, so won't be able to attend HOSP. This has happened during the meeting. She sent her apologies, and if there are any questions on item 6, we can ask for a written response to these. So, do we still want to go through item 6, members? So we've read the report. Has anyone got any questions? So Councillor Graham Heaney, thank you.
Yeah, I do have a question. It's not so much about what we've actually got on the report as what we haven't got on the report. And back in September, we had a brief presentation about the support recovery program that the ICU is going through. And we were promised an update. I think it was in November. We didn't get one in November, maybe because there was nothing to report. But we're now in January and we've not had any information about what's happening on that. And I think that's really disappointing because we're, 3 months before the end of the financial year. And I would have thought the Integrated Care Board would have been able to provide some information. We asked for someone senior. So I'm just wondering if we could ask for, if not a person in now, because we can't do it, but ask for a written update on where we are with their recovery support program, and ask for that as a matter of urgency
for the next meeting.
Well, I think maybe a written update now, as soon as possible. But obviously, if we want to ask some questions, which we may well want to, and we see what they've said, certainly have someone at the next meeting. I'm assuming we'll get in before PRODA. So with a bit of luck, yeah.
So a written report before the next meeting, and
a written report, yeah, and then some opportunity to ask questions next time, yeah.
Yeah, I agree with that. And also, I had a query on this. Hopefully, this could be picked up on one of the questions. Is on page 29, 117. It says national and ICB average rates per 1,000 population for July 2023 were 500, 515 respectively. However, across the ICB, there was a significant variation, rates ranging from 100 to 923. But I couldn't really see that reflected in the graph. It wasn't very clear to me, so I would like some sort of clarity on that as it's been raised by them as well, please. I've also got Councillor Judith Smythe.
Fairly quickly here, I think this is a very encouraging report on one level. It does seem that the patients in Hampshire are receiving a faster service from GPs than previously. Certainly it's something that certainly in my patch, we get a lot of people saying can't get an appointment. And I suppose it's a bit like the question I asked last time. Are we publicising the fact that the rate of, and I'm talking particularly about the table on page 28, 1.1.6, 42% same day appointments. The public doesn't know that. They think that's impossible. A total of 84.62 taking place within 2 weeks of booking. The public don't know that, and they complain and complain and complain, and they don't know that, and sometimes they don't go as a result. So I think we need to tell people that the situation with GP access is improved and it's worth going. Second thing is, I was going to ask what consequences have there been of the gluten-free products decision? And last of all, the dispenser is issuing 25 items is tremendously high in our particular patch. But this is the map on page 31. So brief comments on those all three I think would be in the public interest. Thank you.
Thank you. Are there any other member questions that we would like answered as well, please? Councillor David Evans.
Thank you very much, Chair. If I do find it difficult quite to the general practices are GPs are private practices with contracts to the health service. Now I don't know how that works, and I don't know how the contracts work. And this, what you were just saying about appointments, again, it's an anecdote, so it's a bit flaky, but I had to go for blood tests, and my GP had previously said, could I come in to review my my medication, blood pressure? So I had my blood test, and then I went to the reception desk and I said, I'd like to make an appointment to see my GP because she wants to review. And she said, oh no, I can't do that, because she's not working today, and we can't make appointments ahead of time. We can't book appointments. You can only make an appointment for the day that on the day that your doctor is actually working, and it's 2 days a week. So the point I'm making there is that there is no generality of how GP practices arrange their appointments. It's really up to them. And my experience is that it's going to be extremely difficult to arrange an appointment, at all. But I just offer that in. If anybody's got any similar comments as to why that might be, personally, it could be interesting. Other than that, I shall leave it as.
Thank you, Councillor David Evans. Has anyone else got any questions? I've had sort of a different sort of experience, but in some ways similar. When I've had appointments over the last four months or so, it's mainly been offering appointments to more than 2 weeks later, and then having a timed appointment, say for example for 11:30, but then not being seen until 1:45, and then I gave up. I couldn't be there any longer. But I'm sure we can trade different. There's lots of different stories that we all have experiences. Are there any more member questions on this agenda item?
I was just going to make a comment, actually. I guess each GP surgery has their own system. It's different where I am, so it's not very consistent.
That does make it actually, you're quite right, but that does make it actually quite difficult to analyse GP appointments performance, because all the systems are different. So you ain't comparing apples with apples.
I agree.
Yeah, I guess we never know. It's difficult.
Thank you. Are there any other member questions on this agenda item? Just want to give everyone the opportunity. Okay, so thank you. We know this report, and if we could have a written response before the next meeting, please. So next is agenda item 7, which is adult social care update. And for this, we've got Andy Biddle from Portsmouth City Council. So Andy, could you give us a brief summary of your report, and then members will ask questions. Thank you.
Thank you, Chair. Good afternoon, panel. Thanks for your time. So this is a follow-up, as I put in the overview, to some of the questions that you had when we brought an adult social care report to you in November of last year. In very broad terms, it talks about some of the groups that we work with and connect with rather than run. It demonstrates in the appendices the reach of our independent and wellbeing team in many parts of our community, and demonstrates, I hope, the strength of Portsmouth in its diversity, and shows, broadly speaking, about a third of the users that we connect with, a third of our residents that we connect with through the independence and wellbeing team would be seen as being from ethnic minorities. Very briefly, we had a question about categories. I think that was from yourself, Councillor Evans. And we are wedded to the Office for National Statistics categories, unfortunately. So that's not something we can change locally. And equally with where we're talking about people stating their age or stating their particular ethnicity, we have quite a lot of people that for various reasons choose not to do that. We can't oblige them to do that. The General Data Protection Regulation says to us that we can't make it a condition of the service. So we do encourage people, and we do encourage our colleagues to record as accurately as they can. But sometimes we won't get those statistics. But we do continually review our practice and review the impact of those groups and that support that we offer in those communities. We also have some very active communities in Portsmouth, one of which is the Black African Caribbean community. And sometimes we'll be connecting with those groups, seeing if there's anything we can support them with rather than necessarily running them ourselves. And so members of that community might choose to go directly to those groups that are already set up. And a lot of the groups that we set up, what we try to do is think about an exit plan, so that we're providing the support initially to set them up if there's a need, and facilitating independence with those members. But then if we've got volunteers that continue running them after we withdraw, and that's what we prefer, so we can go on and reuse our resources in other places. We also had some issues raised in terms of the support given to our residents with mental health challenges, one of which was around obtaining a psychiatric assessment when we're in the process of making an assessment formally under the Mental Health Act. And I put some detail there about, it's sort of a sliding scale. If we can work with a doctor that knows the individual well, that knows the resident, that will always be the preference. But if we can't, we go through a series of steps to try and get the best possible medical advice that we can. So it may be a doctor who doesn't know the resident, but they've got a level of expertise and experience within that particular area. Or it may be someone that works in the same locality, but doesn't know the resident. But they always have to have some kind of expertise in psychiatric care. So I've set that out there, and I've included some links. They're quite accessible sites. They give a little bit more information on those resources that we use. And then finally, around mental health, we've talked about the breathing space program. So there are 2 programs in effect when people are struggling with debt. The first is a very generic program that anyone can access. The second is specifically for those people who are coming into contact with us through being assessed under the Mental Health Act and are in crisis. And so those criteria are quite defined. So we do refer other people on to the generic program, but it's only in certain circumstances that folk will come to us under that specific mental health breathing space. And then finally, around the graphs that we produced last time, we talked about, 12 months doesn't really indicate a trend. Do we have a longer time series? We do in some cases, and we'll amend that in future reports. But we're also very fortunate, and I think we discussed this briefly last time, in that we've got 2 analysts, data analysts, working with adult social care. They started with us just before Christmas. And they will be helping us to use our data better, and also to bring more data here to demonstrate to yourselves through your functional scrutiny how we're working, what we've tried, how we adjust and adapt through the data and evidence that we see. Hopefully that's a reasonable summary. As always, happy to take any questions.
Thank you, Andy. Councillor Judah Smythe, I know you've got a question. No. Apologies. Councillor David Evans.
Thank you, Chair. I hope I haven't spoken too much for a very good debate. I had a very simplistic view of what the health service was there for, that it was there to treat people who are ill and basically things of that sort. So I looked up the constitution of the NHS, and it basically says that it actually, I haven't got it printed out, it includes the word well-being. Now, a person's well-being must include, are they taking enough exercise? Are they obese? Do they live in a house that's suitable? Are they earning enough? Do they have public transport? Now, basically, well-being is a catch-all for absolutely everything to do with our lives. So I'm going to state my point is that it's not an appropriate word to put in the constitution of the NHS, because it defocuses from healthcare into just about everything else. Okay, so let me get particularized that into this report here, on going from page 39. ONS is a business about, as I understand it, of a critical friend trying to see how to improve things and pick up things that are not quite as they should be. So on that line, the report on page equalities, diversity and inclusion. Now, this subject, EDI, is coming under a great deal of attention because of the way it's being grossly misused by a number of organisations and politically. So I'm here to challenge. I'm going to challenge a couple of things in this report, because I think the NHS should be spending its money on healthcare, right? But looking down here, we have on the very first page, 39, expected EDI to have improved community cohesion. Well, how's that? Yes, it's a good thing. I don't dispute it. But it's nothing to do with health. There's nothing. It isn't part of NHS, in my view. Equality impact assessed with, I don't know whether there's a better community cohesion. Going into more detail, turning over. Let's just put one other thing that on the page 41. Ongoing delivery of activity sessions. It mentions a gardening group. Reading friends, older men's cookery. I mean, sorry, but if you're spending NHS budget on going out to see a group about older men's cookery, then I'm sorry, you're misspending our money. There you are. That's my statement, and I'll shut up again.
Thank you. So there's a sort of general point to the question to that. So I don't know if Andy Biddle, are you able to give a response to that, please?
Thank you, Chair. So this isn't NHS money, councillor. This is local authority funds. So the independence and wellbeing team works for adult social care within the local authority, partly funded through our public health colleagues who also work in the local authority. What we acknowledge, and one of the driving principles that we use, is if we can help people maintain their independence, help people with their community connections, with their diet, with their lifestyle, we can reduce future draw on the health service, on those acute services that I know you've heard about today from Penny and from my colleague Tracy Redman in the ambulance service. And so the impact of independence and wellbeing is to be preventative. I don't disagree with you. I think wellbeing can cover a multitude of things, and it's a very individual definition. But what we know is that if we can work with people relatively early on in their journey into health and care, that we can reduce the impact of their health and care needs on them, and indeed on services that, for example, if I take a couple of individual case examples that have come to me recently, we've worked with a couple of people at the end of last year who, through various circumstances, partly around cost of living, partly around relationships falling away, not being in work, had become more and more isolated, weren't leaving the house, weren't going out shopping, weren't meeting friends or family, and were gradually in a downward spiral. And we know that that can lead to quite significant mental health effects for people and challenges. By working with them for 4 or 5 weeks, we're able to reintroduce them to community groups, we're able to re-engage them with their local communities, and they then went on to manage that for themselves. And what we believe is, and what we've seen evidence from, is if we help people engage, then they won't need to draw on services, they'll be healthier and their well-being will be improved. So take the point, well-being covers a multitude of things. It really is a very independent individual definition, but we're working, this team in particular is working preventatively. I hope that's helpful.
And those things presumably just cover the Portsmouth City Council area?
Yes, so because of the way that the local authorities are structured, essentially in very simple terms, and Lisa might tell me if I get this wrong, the authority you pay your council tax to is where you get your local authority services from. So in this case, we're talking purely about Portsmouth City Council. There will be very similar initiatives in other upper tier, other unitary and upper tier authorities. Some of those will be electronic, some of those will be face-to-face, and some of those will be a blend or a mix. It's very much been the mantra for a number of years for social care to try and work with people as early as possible to prevent the need to draw on more services later on.
Yeah, I think preventative care is really really important for the NHS going forward. Councillor Martin Pepper.
Yeah, thank you, Chair. Yeah, I just want to jump on the side of Andy if it's two sides, but we're here in Gospel. I don't know how many gardens or bits of ground I've tried to turn into gardens with various groups. So, I've got knees that won't work anymore because of the shoveling I've been doing. But it's always either to stop people requiring more help later in life or later in their career. And certainly once if they get to that stage and have received all the treatment and then just need a little bit of a push over the line to make sure that they don't revert back to type and sort of eat up more and more NHS resources. And I don't want to see this as a resource feeding exercise. But the groups I meet are always just so pleased to be there. The gardening is something that they do whilst they're there, but what they're doing is meeting friends, making new friends, and all that kind of business. So, as far as I'm concerned, we give that as much support as the resources allow. Thank you.
Thank you. Are there any other member questions? I've got Councillor David Evans.
Can I just come back on that as a generality? I've been lucky enough to hear from lots and lots of the voluntary organisations around East Hants, and people many people are extremely keen to help their fellow citizens and do a lot of work, voluntary and unpaid, but specifically in exactly these sorts of areas. There's thousands of these types of groups, and going. If you look at things, I feel one has to be very cautious about how much the state should intervene with people's lives, intervene deliberately and purposefully, and whether the state should be doing it through local authorities. I don't mean necessarily central government, but whether Portsmouth City Council should be doing it, or should actually, is that the best way to do it, or would voluntary groups, small charities in Milton or Fratton or somewhere, actually do a much better job of looking after the people in their village, as it were. I'll just leave that. I'm sort of highly convinced that the state is always the best actor in this, and I'll leave it there.
I just wonder if there's any Portsmouth City councillors who want to come in, because it's our in effect it's our sort of budget area. If not, that's fine. I have a think. Councillor Atwell, please.
Thank you, Chair. Thank you for your report, Andy. I'm just going to page 22, where you're giving all the different activities. I think it might be useful if we actually had the numbers against how many people actually accessing those things, like the shop, cooking, chat, yoga in the park. How many people actually attend those? Thank you.
I think that's just above the list there, Councillor. So what we're saying is about 824 individuals attend the sessions. The number of sessions that were as a totality across all of those groups were 1,463, and the total attendance, and this is from April to December of the last calendar year, the total attendance were 8,160. So we work with, to give a comparison, the City Council in terms of its funded services, things like care packages, care home placements, direct payments, those things that we directly fund. And we work with in the region of about 2,500 people in Portsmouth, solely in Portsmouth. So that's 824 that we're not funding directly, but are attending those kind of groups. And I suppose the other thing that's worth noting is that we do have a lot of charitable organisations in Portsmouth. I mean, I think there's around about 2,000 in total. And Portsmouth, as we know, is a city of small communities and a very distinct identity. And so the IWT team won't exclusively deliver all of this. They'll deliver some of it, but they will work with charitable groups. Sometimes we need some work to get off the ground, that sort of thing. So it's very much a mixed economy. Hopefully that answers your question.
Did you have a follow-up?
Not really, to be honest. I wanted to know, for example, how many people go to yoga in the park? How many of the refugees go to the badminton rock out? That's not
individual numbers at individual sessions is what you're looking for. Okay,
yeah.
I haven't got that, but certainly I'll provide that in a written follow-up if that's helpful.
Okay. Yeah, thank you very much. Thank you.
No problem.
I have to say I represent St Thomas Ward, which part of it is sort of Somers Town, which is a sort of, I guess, a typical inner city ward. And the council and charitable organisations and non-profit organisations have put on some really good events, like the Live Well sessions in Somers Town, where I know we've had 1,000 people from our community attending, and that's been really positive. And people have actually gone on to get involved with some of the charitable groups as well. So that's just a commentary for me, I guess. But I've got Councillor Graham Heaney next, please.
Yeah, thank you, Chair. I mean, I think Andy made the point actually that the City Council does work with voluntary groups to provide these services. It's not the state in the terms it was suggested does it. It's a partnership, and that's actually what's important. And in fact, in my ward, St Jude's, well, St Jude's Church is actually on the border, but they provide cooking classes, kitchens for food. They provide food events, and that's done by refugees very often who actually participate in it, and they provide things for other people. So there's a real partnership thing going on. In terms of things like allotments and growing food, the city council often is the party that has the land that they can make available for things like a community orchard or providing some sort of place where people can grow food, because a part of healthy eating is about being able to sometimes to grow food yourself. Judith will know, because I've taken a part share of her allotments recently and have started growing some for myself. My dad had 2 allotments when I was a kid, so not many people have that, and you need to get introduced to that in a way that helps you, and that's, I think, what these groups are. So that's why the well-being thing, although I think David's quite right, it can be very, very, very widespread. Well-being is about how you become healthy, and healthy is about your relationship with the community. It can be about your mental well-being and health. The fact that you're isolated, you may not look after yourself in the same way you would if you have regular contact with people. So there's those sorts of things, and these sorts of groups and the sort of work that's been suggested in the report here really does help that, and we have to recognise that as well.
Thank you, Councillor Heaney. Councillor Judith Smythe.
I think it's important, and I'm sorry that those of you outside Portsmouth haven't got a similar report, and maybe we should be asking for that. But, Portsmouth is a very poor city. It's also a city where there's lots of activity, and I'm extremely proud of the fact that even though our budgets are very, very much stretched, we are likely to be able to continue this kind of list into the coming financial year. And one of the things that parties will be doing in our budget discussions is preserving these, and the majority control is with the Liberal Democrats combined with the Labour Party, and we're likely to be able to preserve these things. But I do think local politics come into it, and you need to be asking these questions of your districts and the Hampshire County Council, who I know is in trouble.
Just to be clear, Portsmouth City isn't Liberal Democrat and Labour. It's got a Lib Dem cabinet, but there you go. But that wasn't your point.
Well, that's what I meant. That's what I meant. But I mean, I do think these things are somewhat historic and somewhat and very important in terms of, I think politics do matter in that context.
Yeah. Thank you. Do we have any other member questions? No, so thank you very much, Andy. We note your report again. If you want to stay, you're very welcome to stay. But if you need to leave the meeting, we understand. Thank you for your report.
Thank you, panel.
So next, we're going to agenda item 8, which is a public health update from Matt Gummerson. So Matt, over to you. So Matt, could you give us a brief summary of your report, and then members will ask any questions they have. Thank you.
Of course, thank you, Chair, and apologies from Helen Atkinson, Director of Public Health, who is on leave, which is why you've got me. I'm one of the Assistant Directors of Public Health, and I lead on intelligence and research within the Public Health team in Portsmouth. So the slides that you've been sent cover and summarise kind of key activity and progress across the breadth of activity, breadth of areas that Public Health Portsmouth cover. Includes services that we commission, those we provide directly, and those that we support in partnership with others. I'm not going to go through all of the slides in detail as you had them. I will take the liberty as I'm presenting it to highlight the work of the Public Health Intelligence team that's on page 54 of your report pack, or fifth slide. So a number of things that we've delivered in the last few months. We published a Public Health Annual Report looking at poverty and the cost of living impacts in Portsmouth, and that will be going to Cabinet and full Council shortly. And we've also got data around the impacts of cost of living in Portsmouth available on the Joint Strategic Needs Assessment website, where we've also recently published updated demographic data and information on health and social care needs of children and young people, with further updates to come. We've also completed the strategic assessment of community safety, supporting the work of the Safer Portsmouth partners that sit under the Health and Wellbeing Board. We've also had some really good news recently. We successfully bid to the National Institute for Health Research for funding for Portsmouth in partnership with the University of Portsmouth and Hive to be a health determinants research collaboration. So this is 30 local authorities across the country that will become kind of centres of excellence in delivering research into the wider determinants of health and how we can better have the evidence we need to do the things that will improve those. So we've got a development year this year, and then we'll be starting in January next year. So happy to come back and update on that once it's in progress. Elsewhere in the report, just to flag up one thing that we were asked to do was to provide a bit more information around trends and outcomes around some of the things that we're delivering. So we've included that where we can within the report. There is one small caveat around that, which is that a lot of the trend data we receive from the Office for Health Improvement and Disparities via their fingertips websites. They're currently in the process of updating the population figures that underpin all of those rates that allow us to do trend comparisons. Those will be, some of them have been updated now. We're expecting a load more in February. So there are some indicators where we don't have trend data at the moment, while they rebase the previous year's populations. But we will certainly update on those elsewhere. But there are some where we have included them, and I would draw your attention in particular to one of the areas of ongoing challenge, which is around children's healthy weight. So from page 61 in your pack, there's 6 pages that cover children's healthy weight, and then also adults' weight and activity as well. But you'll see on the children's healthy weight one on page 61 in particular that Portsmouth's rates of obesity amongst children in reception and year 6 continue to be significantly higher than nationally, broadly similar to other cities with the experience deprivation similar to Portsmouth, an ongoing challenge. But the slides also explain all of the activity that's going on to address that, both with children and with adults. And I would say, these are the things that, listening to your earlier conversations around challenges around acuity, challenges around presentations at the Hospital Trust, these are the things that we need to address now so that we're not facing further increases in the acuity of patients, further challenges and pressures on the health system over the next 50 years, because that's what will be a kind of key driver in the future. So lots going on, lots of good progress, but still challenges around our relative position on outcomes. I could carry on and talk through all the detail in the slides, but I'm very happy to take questions on those areas that you're particularly interested in.
Thank you, Matt. Over to members. I wonder if there are any member questions at all. By the way, Matt, thank you for including more data over a longer period of time. That's what we really wanted. So thank you for that. So are there any member questions following on? So I've got Councillor Atwell first of all, please.
Yes, thank you, Chair, and thank you, Matthew, for the report. Just going on regarding the drug-related deaths. Mm-hmm. In the graph you're showing here, I know it's maybe slightly out of date, but it does look like those deaths are on the increase. I just wondered. Yeah.
So this is on page 57, is it?
Yeah, 57. Yes.
Yeah.
Now I noticed you've got some improvements there, but do you see those starting to work now? Is the trend starting to reverse?
Yeah, I think what we're starting, the trend nationally is continuing to worsen, and I think you will. So our relative position is improving in that it's come down a bit from its kind of peaks in Portsmouth. So the gap between us and nationally is improving, but it's still a challenge. That data, as it acknowledges in the slides, there's quite a long time lag on having the updated data around that, and there's been a significant investment, as the next slide details, in addressing drug and alcohol services in the city. So there's lots of investment that's gone in that we are confident will lead to continued improvements. So I think the position is improving, but there's still lots to do. But there is a lot of investment nationally in substance misuse services and locally in those, and so reasonably confident that should get better.
So hopefully, do you know when we might see some updated data on that then? Just wonder why it takes so long as well.
Yeah, so the reason it takes so long in terms of doing drug-related deaths is because of the kind of process between when a death occurs and then when the causes that death attributed to are, and then that comes out annually, a year in arrears, that we then get updated data on that. So it's quite, and the these deaths are often ones that are quite complicated. There's a range of factors at play, so assessing a death as being drug related is not a simple a matter as some other mortality, unfortunately. That's the reason. I can let you know when that data is due to be updated. I don't have it to hand, but I can find out for you.
Okay, thank you very much. Thank you.
Thank you. Next, I've got Councillor Graham Heaney.
Yeah, it's actually on the same table, but I was interested in the data from quite a while ago. As you can see, it shows that figure from 2003 going 2004. There's a sudden drop, and it stays at a fairly low level. And I'm wondering if we know what the reasons for that were, whether it was just one of those sort of statistical blips, or whether there was things happening then which may well have helped to keep the level low. It's obviously still above the England average, but it was still a lot better than it is now. And do we know why that was?
I don't. I'm afraid I can ask Alan Noble to lead some issues. I'm sure he will. He's been around working in this area for a very long time, so I'm sure he'll know what the kind of context around that was at the time.
Yeah, would we be able to have that in a written sort of reply? Would that be okay?
Yeah.
Thank you.
Yeah, that'd be fine. Yeah, that'd be helpful. Thank you. Yeah, thanks for that.
Thank you. Are there any other member questions? No, I think that's it. So thank you very much for your report. That's noted, Matt. You're welcome to stay for the end of the meeting, but equally, if you need to go now, we understand. So thank you. Okay, so the next agenda item is dates of future meetings. So on the agenda, the dates of the future meetings are listed, and we just want to check whether members are happy with these dates. Now, there will be a new health and scrutiny overview panel from May onwards, but we just want to diary in those dates. So do we have agreement that those dates are okay? Any people? Councillor Graham Heaney.
I mean, I'm okay with the June one, but my problem is I never know what my timetable is going to be for the university teaching, so I have no idea whether the ones later going to. That sometimes happens. I get caught out, so I'll have to just take my chances and hope they don't put scheduled teaching for when you've got the dates on. And if I am aware of that, I'll try and get them to change it if I can.
Yeah, it's quite difficult for us as well, isn't it? Because we get the panel gets reappointed in the new democratic year, as it were. So, Councillor Judith Smythe.
As long as none of these are Mondays, I've got another 2.5 years of childcare to provide on Mondays. Then I can manage all of these as far as I know, if I'm reappointed. Are there Mondays?
Lisa, do you know off the top of your head? I think they probably aren't, are they?
No, I think we stuck with Thursdays.
Thank you for that.
Good. Excellent. Excellent.
Councillor Stuart Brown, please.
No problem with the dates, but obviously if the revised start time does change to 10 a.m, I will probably have to not rejoin the panel next year. I have a standing work meeting every Thursday at 11 a.m, so a 10 a.m. start would completely clash with that for me.
So just moving on to that, I was contacted by a member who has young children, and the suggestion was that it would be better for them at 10 o'clock in the day. So we're not necessarily thinking of arranging meetings around one person, but actually if we want different people to attend meetings, that was a suggestion. So this is over to you to see what you thought about that as a concept, and also about whether we should have the meetings in person. They used to be in person, and so the obvious thing is the convenience for people attending who can be running large organisations would mean that they would have to mainly attend in person unless there could be a hybrid meeting. And this was, I think, adopted during COVID, but actually, we're not seeing people face to face, and there can be advantages in that. So I just wondered what people on this committee at this moment thought. It could be reviewed again with a new panel in the future. But do people have opinions? I've got Councillor Graham Heaney. Sorry, apologies.
Yeah, I'm happy to be as flexible as possible. I mean, I'm probably lucky in one sense that the university does give me some flexibility at certainly timetabling the problem. So I don't have a problem with the change of time as such, if that does help potential members of the committee to be able to go. But we could also try and just maybe do a little bit of a survey around potential members once the committee's been established, and just see if the time, because we don't know who's going to be on, might be some new members come on, some might come off. It's then now maybe to check and say what's the best time for all of them, and then we can agree what that is, and that might be the better thing to do around that. So
yeah, that was my thought as well. But Councillor Atwell,
just a minute about meeting
sorry.
in person. So I just meant the meeting in person. I mean, I'm very happy to meet in person. It's quite nice to do, but I think we could be flexible for particularly for working in the health boroughs who may not necessarily want to travel to meetings somewhere, but and have hybrid meetings. So that if some, and occasionally it might be difficult for members to come. So if they can do that, the hybrid one would work well.
Just on that point, Lisa, is that possible in the rooms that would be available to have a hybrid meeting? We can come back to that. So Councillor Atwell.
Yeah, so if it was to be at 10 a.m. on a Thursday, I would struggle with that because I chair another meeting between 9 and 10. I'm quite happy to meet in person, but it'd have to be a bit later than 10 o'clock. So I think what Graham's suggesting is a good idea. Once whoever's reappointed can look at the timings then.
Thank you very much. Councillor Judith Smythe.
I think it would make it possible for both people who are concerned about the pick-up at school and those who've got meetings in the morning to meet at 12:30, and 1 o'clock would even be better. I was certainly free at 1 o'clock, but I'm now impinging on time I'd use for something else naturally. And I think hybrid meetings are really not good. It's very, very difficult if you're in the meeting not to notice when others not in the meeting want to put our hands up and so forth. So I would be happy with in person, but I don't like hybrid meetings personally, and I think a lot of people don't.
What about between online and in person? Have you got a view about which one of those you prefer?
Well, I prefer in person, but I as long as it's either hybrid or online, or perhaps half and half. But hybrid meetings are very difficult.
Okay, thank you. Next, I've got Councillor David Evans, please.
Well, I generally like in-person meetings in favour of Teams meetings, but I do live in Horndean, which is quite a trek down to Portsmouth, and so I'm quite happy with this meeting being on Teams personally. Whether it's hybrid or not is another factor, but that's my personal view.
Okay, next, thank you. Next, Councillor Martin Pepper, please.
Thank you, Chair. On the hybrid thing, I think the presenters could be coming in over the air, and the group together, I would preference, but particularly for the first meeting where you don't know who each other are, and it's helpful to have a little face-to-face. After that, it becomes, I would suggest it becomes less important, actually. But, the first meeting is very helpful.
Thank you. So it typically, I thought this would happen. We've got a lot of different views. Could I propose that we come forward at the next meeting with a proposal for the new democratic year? And then I also think the same thing as Councillor Heaney and Councillor Atwell have mentioned, that actually I think then the new panel should review what they want to do. I think that would be fair to the new panel. Is that proposal seconded by anyone?
Yep, second up.
Do we do a vote in favour?
Agreed.
Okay, so we'll put that forward for the next council, for the next Health and Overview Scrutiny Panel meeting, that proposal. So thank you. So thank you, members. That's all the items on the agenda today. The next meeting is scheduled for 14th of March online at 1:30 p.m. And I officially close the meeting and ask Lisa to stop the live stream.
Thank you, Chair. I'll let you know when we're off air.